want to share with you why I believe that Scotland is admired for more than the things that naturally come to your mind. Tell me something. What comes from Scotland and is 12 years old? The whiskey is good, but I'm going to talk to you about the Scottish Patient Safety Programme, which is also 12 years old and quite tasty too. Before moving to Scotland, I worked as a project manager in the UK and in the Middle East, and followed this then with 12 years working in Scotland for the National Health Service. I work as an improvement advisor involved in the Scottish Patient Safety Programme, or SPSP, as I will refer to it for brevity. In 2015, I completed a programme of training called the Scottish Improvement Leader. We've heard already today about the power of education. I'm not quite sure whether I scored a B on that particular one. But this transformed my old style of thinking, my old project manager style of thinking. Absolutely transformational for me. I'd like to share with you some reflections of a country that's taken a focused approach to improving safety and reducing harm in healthcare. Why does this matter? During the development and scoping of the SPSP, global evidence suggested that nearly 1 in 10 patients admitted to hospital would be unintentionally harmed, and that over 40% of those incidents could be avoided. In Scotland, we share our work widely and steal ideas shamelessly from each other. So I thought I'd maybe come and steal and share with you guys. In terms of scale, there may be some parallels between Cyprus and Scotland if you look at the numbers on the screen. I work for a rural health area, Dumfries and Galloway, which has a small population spread over quite a large area. In my view, one of the key factors for progress in Scotland has been its ability to set aims and manage progress across all of its health boards at the same time, a concept that might be of interest in Cyprus, perhaps. Let's find out a little bit more. After a pilot period, SPSP was rolled out to every Scottish health board in January 2008, the world's first whole-country patient safety programme. The Scottish Government worked in collaboration with the Institute for Healthcare Improvement, or IHI, from the US. The programme aims to improve the safety and reliability of healthcare and reduce harm. Early focus was on reducing harm in the acute adult setting. Tools such as the IHI Global Trigger Tool were instrumental in identifying avoidable harm, while incident reporting and risk management tools were helpful to measure progress and to help prioritise that work effort. By the end of 2012, there were early successes around hand hygiene. Less people were coming into hospital and acquiring infections such as MRSA, and other aspects of infection reduction were beginning to show. Health boards had developed small units with skills around quality improvement tools and techniques. And initiatives such as Safety Culture Survey were deployed to help clinical areas understand how behaviours might be developed alongside changes to clinical processes. At a national level, leadership was provided to prepare evidence-based bundles of work which suggested improvement ideas alongside a programme of measurement. As part of the recognition that SPSP had much momentum, health boards were directed by government to implement a range of patient safety essentials, key practices which have proven to reduce harm and improve safety and reliability. Much learning was taken from the airline industry crew resource management practices and reshaped to fit a healthcare environment. Much education was being delivered by government along the lines of human factors and ergonomics, as well as spreading the use for the model for improvement methodology. This saw a transition of now well-established interventions from being tested at small quality improvement scale to being rolled out nationally as part of day-to-day care. So how was this work resourced? There was little or no money for additional clinical resources. A small number of national and local improvement advisor posts were funded, largely filled by clinical and nursing staff who were excited about the new methods and skills available, while the post attracted some external experience, for example, people with project and change management backgrounds, just like myself. By 2013, additional programs were developed, including primary care, mental health, and medicines. This spread takes key components, safety culture, the model for improvement, and some new leadership and coaching styles, and spreads them across areas of the health arena. Additional packages of improvement work were identified, along with measurement plans, so that leaders and staff were able to know whether their change ideas resulted in improvement. New education programs were developed and offered to enable existing staff to undertake quality improvement work alongside their clinical roles. This is an example from dentistry that I was involved in back in 2016, 2017. They had no tools for recording incidents. Even without those tools for recording and reporting on incidents and adverse events, patient safety initiatives we saw can still commence and focus their aims as the existing systems are investigated. Baseline data was collected and reported in the form of run charts, like that you see on the screen, to illustrate reliability over time and to subsequently illustrate how the improvement work affects the outcomes for patients. The program expanded to support improvements in safety across more areas, including maternity, neonatal, and pediatric services, as well as care homes now. Underpinned by the robust application of quality improvement methodology, SPSP has brought about significant change in outcomes for Scotland. The current acute patient safety program became very, very wide, but has now consolidated down to some key priority areas. Health boards are encouraged to use their own systems and adverse event management and use their own QI-capable staff. They use the now common quality improvement approaches, tools, and techniques to realise their patient safety priorities. There's been lots of mentions of systems today, so I wanted to mention a system called Datix that we use in Scotland for incident reporting and risk management, and also more recently a system called LifeQI, which we use to administer our improvement projects. Traditionally, we've not been good at making change for improvement reliable. After designing a change, we tend not to test whether it will be delivered appropriately in various conditions and environments before we expect everybody to just implement it and make it part of everyday business. You ever come across that situation where you've been asked to use a new form that simply doesn't apply to you and wasn't designed in your departments? The quality improvement approach, in contrast, focuses on where the work is done at the front line. Ideas are created and tested by frontline staff where the work is done through small-scale testing and learning from each small-scale iterative test. When I was a project manager, we designed things in a dark room as a bunch of experts and then did them to people. That's all changed. A typical program of work takes this form, as you see on the screen, as prescribed by the Institute for Healthcare Improvement, comprising the development of a framework for improvement, aims, drivers, and change ideas, with leaders adopting a coaching style, ceding power to practitioners, and flattening hierarchy. I'm going to say that again because it's so important. They work to flatten hierarchy. There are periodic learning sessions between action periods, combining testing of change ideas with formal learning. Measurement plans are developed to help to determine the effectiveness of change in terms of process, outcome, and now value, something that we didn't talk about much over the last 10 years, but the financial aspect is starting to come into our measurement plans now, which is very interesting. Frontline staff are encouraged to come up with change ideas and are given permission to test them safely on a small scale using the Plan, Do, Study, Act, or PDSA cycle. The approach for application of quality improvement for patient safety is well established. This is a screenshot from one of the Scottish Government patient safety websites. Education programs have been developed for lead level and practitioner levels, delivered nationally and in each local health board to increase capability and capacity for quality improvement. So we're looking to normalise that QI culture. In Dumfries and Galloway, the small board where I'm working, we have a small faculty delivering classroom-based courses for quality improvement and patient safety based closely on the programmes developed by the Scottish Government. Delivered at a leadership and practitioner level, this is supported by provision of regular coaching style sessions addressing cultural and behavioural change alongside workplace support. Every 6 months, we see a new cohort of improvement practitioners. Each has delivered an improvement project relative to their own clinical work area. Practitioners are encouraged to try new ideas, to engage with patients, and to use their feedback to develop their improvements. We've started to see quality improvement included now within job descriptions and within recruitment advertising. It's becoming the norm for people to be involved in QI, delivering services to patients that are safer, more reliable, and patient-focused. So this is my last slide. These posters were produced by recent graduates from one of our QI learning programs. Over 6 months, the sessions cover key QI, patient safety, human factors, and coaching skills. Every participant graduates by producing and presenting a poster of their improvement journey. So in summary, capability and capacity around quality improvement methodology is key to developing and delivering safer patient care. Success is most evident where quality improvement becomes part of everyday culture and is practiced from the most senior staff through to the most junior. So be sure to Google SPSP. There is much to see online. The Scottish Patient Safety Programme is not over yet. In 2018, SPSP celebrated 10 years, and I'd like to finish by sharing with you a short video of some of its architects reflecting on these 10 years. And all of this content is available on the internet.
I think Scotland has a number of advantages. It's a small nation that thinks big.
It's about engagement and putting the patient at the centre of our care. We are encouraged to be safe and reliable practitioners through the Scottish Patient Safety Programme.
I think the key ingredients for the success of SPSP have been belief, commitment and a relentless focus on improving the quality and safety of care for the people of Scotland.
The impact that SPSP has had internationally is significant. In Healthcare Improvement Scotland, we regularly get requests from individuals from all over the world to come and visit and learn about the work we're doing in Scotland. And one of the areas they're always interested in is our work around the safety programme. And in particular, they are interested to know how we've managed to deliver improvements across such a diverse range of settings. So not just the acute hospitals, but mental health, primary care, and more recently into our care home sector.
There's a few words I'd use to describe SPSP. The first one is courageous. It was the first, and it was the biggest safety program that I've ever seen. The second one I'd use is innovative, because I think the idea of setting a tempo for the pace of change and learning from each other and from other industries has been really innovative. And the third I'd say is inspiring. What we're seeing is that people across the country who never talked about safety, who perhaps didn't see safety problems as their responsibility, are inspired to come and work together on behalf of patients and families everywhere.
I think it's important at 10 years of the Scottish Patient Safety Programme to do two things: to celebrate the success and to thank the staff who have delivered that success. And I would genuinely congratulate the professionals across our country and in the health and social care system who have delivered the infection reductions, the mortality reductions and the culture change that we all can see.